All right, the last lecture I'm going to do from this chapter is on the testicular disorders. So for testicular disorders, there's a lot of different definitions that are utilized. So I'm just going to quickly kind of go through these. We have something called cryptorchidism, which is where you have an undescended testes. This is significant because when you have a male whose testes took a while to descend or they never descended and they had to go in and surgically descend them, they're high risk for testicular cancers. So that is always significant in a patient's history. There's something called a hydrocele, and that's where they get fluid in the scrotal sac. You can actually see this pretty easily using a transillumination test where you literally just take a flashlight and it will illuminate the fluid in the sac. A varicocele, this is varicose veins of the scrotum. This sometimes will require surgery to remove the varicocele, especially if those varicose veins rupture. There's something else called epididymitis, and this is an inflammation of the epididymis, but it can also be an infectious process. Okay, so epididymitis is pretty common, but you need to be on high alert when there is inflammation because we also need to be suspicious of a bacterial infection. So a lot of times we'll go ahead and treat this with antibiotics. And then the last thing we have is orchitis, which is a testicular inflammation or infection. And again, this is just of the testes at this point. Can be secondary to other things like the flu, mono, pneumonia, mumps. These are all things that will cause testicular inflammation. So we need to be looking for whatever the secondary cause is so that we can rule out any issues there. Oops. Okay, so testicular cancer, this is something that we're going to talk a little bit about in this recording. Risk factors for this, cryptorchidism, like I just said on the previous slide. So any history of undescended testes is always significant and is a very significant risk factor for testicular cancer. There is a familial linkage with this, so family history would be important to know. DES use by the mother, this is something that hasn't been used for a very long time, but it is important to note because if the mother, or like let's say your grandmother used DES when she was pregnant with your mother, that is in her DNA also, if that makes sense. And it was a drug used to prevent miscarriages. So DES use is significant. And again, we don't see women using it today to prevent miscarriages, but it was something that was used several decades back and is still significant in terms of testicular cancer. Higher incidence among Caucasians, and also higher incidence among high socioeconomic status. So signs and symptoms. So early on, the male will find a painless lump over the testes and usually unilateral swelling on one side. And a lot of individuals will say that it feels heavy, that the testes feel heavy. This is why we have to do self-exams, testicular self-exams every single month. And our teaching with this is that we teach the male that the easiest time to do this is after a shower, for example. That we need to be educating our male patients about the importance of early identification because this is something that does metastasize very quickly. Okay. And when it does metastasize, we're looking at back pain, shortness of breath, difficulty swallowing, vision changes. So the later symptoms are much more catastrophic than if we are teaching our men about the importance of testicular self-exams. Diagnosis for this, we can do an ultrasound of the testes. The chest x-ray would be indicative of any metastasis to the lungs, for example. We can do blood for tumor markers like HCG, which is actually the pregnancy hormone, but you will see an elevation in that with testicular cancer. And then just like all of our other cancers, we always biopsy to get confirmation of diagnosis. And then we want to stage this to see how aggressive we're going to get with our therapeutic interventions. Therapeutic interventions are going to include, our surgery, our radiation, our chemotherapy. And again, it's going to be very, very crucial that we, catch this as early as we possibly can because the mortality rate for late stages of testicular cancer is actually quite high. So nursing care for our testicular cancer, I've said this already multiple times in this lecture. We were going to teach testicular self-exam. So we teach our young men about, how it should be performed, when it should be performed, and there's more information on this in your assessment chapter of reproduction. We want to provide emotional support, okay, because this is a detrimental diagnosis. So we want to provide emotional support for the patient and their family. We want to discuss the possibility of sperm bank deposits. Testicular cancer usually affects young men, and it's not uncommon for them to be diagnosed before they have had an opportunity to have children of their own. So we do want to discuss sperm bank deposits before we begin any chemo or radiation. And then we want to make sure that we offer a cancer support group, okay? There's a lot of cancer support groups out there that are, face-to-face, online, so that, the individual knows that they aren't going through this alone. Kind of switching gears, we're going to switch over to the vasectomy. Vasectomy, this is where there's an interruption in the vas deferens within the testes, and this is a method of what they consider permanent birth control, okay? What they're going to do here is they're going to clamp the vas deferens and they're going to cauterize it, and in the attempt that, this is considered a permanent birth control method. Now, that's not to say that it can't be reversed, because there's been several times where the vasectomy has been able to be reversed, but we do consider it a permanent form of birth control. It is important to educate the man, and especially if he is with a female, that this procedure is effective 3 months following the surgery. So it's very, very important, if they're using this as a method of birth control, that they continue to use alternate forms of birth control for 3 months. And what they'll do is they'll have the male bring in a specimen, and they'll evaluate it to see if there's any evidence of sperm or motility in the specimen. So here is a picture of the vasectomy and the reversal. Okay, so at the top you can see where they make the incision through the vas deferens, and then the vas deferens is pulled through the incision, and then it's cut. And then each end is tied off with suture before the incision is closed. And you can kind of see that at the bottom where it's just completely disconnected. Now, what they do if they want to reverse it is they just go in and undo what they did. So they'll take the ends of the vas deferens and they'll suture them back together. So this is not something that needs to be done over and over again. Like most people, when they get this done, there is a chance that if they do get the vasectomy reversed, that it may not be effective. So a lot of your doctors want to make sure that you have thought about, the possibility of having kids. And if it's certainly something you don't want to consider in your future, then yes, they will, they'll do the vasectomy. But keep in mind, like I said, it can be reversed. It's just, it doesn't always, it's not always effective when they do reverse the vasectomy. All right, moving on to erectile dysfunction. And this is where there's a problem obtaining or maintaining an erection. So most men will experience temporary erection problems at some point in their life. And when it becomes persistent, that's when we want to make sure that we educate about seeking medical help. So when we're looking at erectile dysfunction, we have to rule out physical causes versus psychosocial causes. So physically, we're looking at how's their circulation. Do they have atherosclerosis, which would be preventing blood flow from getting where it needs to go? We need to look at their nerves. We can do nerve conduction studies and make sure that all their nerves are in check. We can check hormone balance. Okay, we want to make sure that their testosterone levels are effective and all of our other hormones are in check. We can check the limbic system in the brain. We can check them for obstructive sleep apnea, because hypoxia can be another problem that can precipitate erectile dysfunction. Psychosocial, so once we've figured out that physical is not an issue, then we're going to look at the psychosocial. Are we looking at an individual with a lot of stress in their lives? Are we dealing with someone who has chronic illness? Someone who's fatigued? or someone who is under the influence of alcohol or drugs. These are all things that can lead to erectile dysfunction in men. So your diagnosis, we want a history. We want to know their medical surgical history. We want to know what medications they take, any types of substance abuse, what their lifestyle is, and what their sexual history is. These are all part of their history when we're ruling out erectile dysfunction. Blood test wise, again, we're going to look for physical findings. We want to check their glucose level. Are we dealing with a diabetic? We want to know what their testosterone levels are. We're going to evaluate their circulatory system. So again, we're looking for any evidence that there is plaque formation that is disrupting blood flow. And a psychosocial eval. We want to see psychologically, are we dealing with something there? Once we have determined that everything else that has been ruled out, now we're going to start looking at our therapeutic interventions. So maybe it's a medication change. We've talked about how the antihypertensives are known for causing erectile dysfunction, or certain ones. So let's look at some different medications. We may have to add oral medications like erectile dysfunction medications. You've got tadalafil, which is your Cialis. You have sildenafil, which is Viagra. You have vardenafil, which is Levitra. So this is a booming drug class on the market, so there's no short supply of oral medications for erectile dysfunction. We could do hormone therapy, but anytime we do hormone therapy, we want to make sure that we have ruled out cancer first. Okay, we certainly don't want an undiagnosed cancer, and then we decide to give hormone therapy, which can actually exacerbate these cancers. So we're going to make sure there's no cancer before we initiate hormone therapy. We can look at oral remedies. We can look at medications. There are erectile dysfunction injections. There are transurethral capsules that you can insert into the penis before sexual intercourse. So just if we're doing a transurethral, obviously one of the big things we teach our patients is that they need to urinate, empty their bladder before they insert a transurethral medication. There are devices, and on the next page I have pictures of penile implants, or some of the pumps that they have to increase blood flow to the area. And then again, surgery, like I said, I'm going to show you a picture of some penile implants. And vascular surgery, we may have to do cardiovascular bypass or vascular bypass to redirect blood flow so that it gets where it needs to go. And then here's pictures. These are two different types of implants that you'll see. You have the inflatable kind versus the non-inflatable kind. And both of these are on the market and available for implant surgeries, and a lot of men have a lot of success with both of these types of implants. For erectile dysfunction, nursing diagnosis, we're looking at readiness for enhanced self-health maintenance. So it's important that we educate these men that they're not alone with this problem, okay? So we want to make sure that our patient understands the problem and are satisfied with the treatment process, okay? And we also need to make sure that our patient is in the right mindset to learn, okay? Because if they're not in the right mindset yet, you can educate all you want and they're not going to listen. So we want to make sure that they understand the problem and that they are satisfied with the treatment process that we've come up with. All right, last couple things in this chapter is on infertility. There are 3 general causes of infertility in men. We have pre-testicular, which is pretty rare. That usually will be like endocrine, like your hypothalamus, your pituitary, testicles, any type of hormone imbalance. That's what we're going to be evaluating here. Testicular, we're going to rule out the varicocele, because what we can see here is you can have we can increase the blood flow, and it can increase the temperature in the testicles, and that certainly is not appropriate for fertility. Okay, so we're going to check and make sure there's no varicocele. We're going to check and make sure it's not idiopathic. Is there a fever? Is there an underlying infection? And post-testicular, we're going to look at, have they had surgery? Is this an individual who's had a vasectomy? Is this someone who's had bladder neck surgery? These are all things that can cause post-testicular infertility issues. So for diagnosis, we want a detailed history. We want to know about their sexual practices. We want to know about their lifestyle practices. We want to know about their occupation, their medical surgical history. We're going to do a physical exam on them and make sure they're healthy. And we're going to do a semen analysis and see what we've got going on there. Therapeutic interventions. So once we find out what their lifestyle practices are, we might want to talk to them about a change in their lifestyle practices. It's not uncommon for a lot of adults to not fully understand how the reproductive cycle works. So we may have to talk to them about their lifestyle practices. We may have to do surgery if indicated. And then there are in vitro procedures, and I'll talk more about that with the female reproductive system. But it's a lot more invasive for a female that's infertile than it is for a male. Usually the male, they're an easier fix than a female that's infertile. So that's why we're talking about this one first here. Okay. All right. That wraps up the reproductive chapter.